So I wish we had all the answers in order to give you an explanation of what is happening. There's a couple of things that I will try and do. We'll try and talk a little bit about what we think might be the starting point. Go back. Might be the starting point, and a little bit about what might be progression as it goes on in the disease. But all the patients arrive with the disorder. We don't know when it started. We haven't got a clue about the initiating components. And so most of the understanding of this particular disease relies on some experimental models that we can try and do in animals to try and initiate the process of fibrosis and then try and investigate. And that's been true, I guess, now for about 25 years. So we've been looking at what are the cells involved and what are the molecules involved in trying to understand this progressive disease now for over 20 years. And yet, to date, we really still do not know exactly what are the molecules that are the most important and therefore targetable, although we've now come closer to an understanding, and you'll see that, nor do we know which are the actual cells that we should try and manipulate in order to get to it. So there is still an awful long way to go, but we have come an immense distance already in looking at this disorder. Now, if you read, or if you Google and you read any of the reviews around, you'll see more and more and more of these relatively complex, big diagrammatic schema. And it's just an indication that there's more and more interest in this disorder. Not so much in idiopathic pulmonary fibrosis, but in fibrosis in general. So if I was to tell you that 25 years ago, if we were talking to an audience about idiopathic pulmonary fibrosis, there would be 3 people there. It'd be my mother, my father, and somebody who missed the bus. The interest in fibrosis grew as we worked independently in different organs, and suddenly we're working on the same pathways. So we understand now that the fibrosis that's present in the kidney is very much similar to the fibrosis is present in the lung, or fibrosis is present in the heart. And therefore, a lot more information can be pulled together from a lot more disparate types of laboratories in order to try and get some common understanding. And indeed, the pharmaceutical industry has grasped this idea of fibrosis as a targetable disease as opposed to individual types of fibrosis. And so that's been a big benefit in trying to generate these issues where injury to the area that you saw originally was important, the microtrauma, was then followed up by repair. And that's really what the whole thing follows up about. Now, let me go to this issue that I'll try and deal with through 3 areas quickly about what we might think starts it, what we think about how it progresses, and then the involvement of exacerbation in the process, and then finally finish up with maybe some of the recent work on looking at the treatments of it. So we know that there are injuries that will cause a response to repair, and the repair can be abnormal, and under those conditions you can get a scar, regardless of the particular tissue you're looking at. In the case of the lung, you can certainly, as we heard about asbestos and silica, radiation damage, or inhaled allergens can also cause these repeated types of injuries. And you have to look at the anatomy of the lung in order to understand that out here in the alveoli, so we got the larger airways, out in the alveoli, so we've got 2 or 3 different cells. We have the type 2 pneumocyte and the type 1 pneumocyte, and on the other side of that, we have the endothelial cells, and in between them, we have cells for structure. We have fibroblasts. And it's the injuries that appear to occur out here in the alveoli that we're concerned about, because it appears to be those injuries that give rise to the progressive nature of disease. So the concept of an asbestos particle or injury or smoke then dealing a death blow to one of the epithelial cells. And that death blow means that that cell dies. Either it undergoes apoptosis or it undergoes necrosis, but it's no longer there. And indeed, it can expose the basement membrane. And we think that that is one of the premier triggers for the progression of repair, and repair bringing into that area a whole series of other cells. But this is probably what happens in the initiation stage, and it might happen a number of times. So We do know that that injury to the epithelium normally is involving messages that cause repair, inflammation, and this pathway to normal recovery occurs in about 99.9% of the time. We get this all the time. You breathe in smoke, you breathe in a variety of inhaled pathogens, you get damage, you get repair, and your lung repairs back to normal. That's normally occurring. But two pathways that we know that can end up causing disease. One is where you build up this increased scar tissue in the interstitium between the airway and the blood, so you don't get the right exchange, and that thickening of that area is what we think about now as the mechanisms. Or you don't repair it correctly and you continue to degrade the alveolus and you open up large holes, and therefore you develop a disease called emphysema. Both of those are lethal disorders, and yet there are many, many molecules that we've now studied that are involved in the exact same processes. So which ones cause it to go in one direction or which one cause it to go in another direction is an area of active investigation. Nonetheless, there are two or three things that have to occur in the process of repair. That's the injury. The cells that we know that are involved in it are normal cells, the epithelial cells. We know that the basement membrane exposure is a critical element that causes these next stages to occur. We know that there's multiple growth factors and other cells that come in to causing that repair. We certainly know that you have to regrow blood vessels. We also know you have to regrow nerves in order for the tissue to repair. So we're looking at mechanisms that will cause this angiogenesis. We've also got mechanisms that cause the neural cells to regrow. But it's this area here that we think really concentrates on a cell population called the myofibroblast, which is simply a fibroblast that has got muscle cell-like capacity. It contains a molecule called smooth muscle actin that causes a cell, which we used to think as being an inert cell that you built yourself off of, to become one that actually can move, can change, has got contractile capacity, and makes an awful lot of these extracellular components of molecules that we'll call collagen. We'll come back to that in a minute. So, in reality, for the disease like IPF, it doesn't matter how it starts, because by the time the patient arrives, there's a different set of mechanisms going on. And the mechanisms involve this progressive nature of disease. And it's progression that we have to understand as opposed to how it was initiated. So, for example, there's a disease that we do know about causes pulmonary fibrosis that can be caused by X-rays. So radiation damage can give rise to pulmonary fibrosis. It's progressive, like pulmonary fibrosis of IPF. We know exactly when it started because the radiation date and the amount of grays that the patient received are already on record, but we still don't know the actual mechanism of progression. So it helps to know what started it, but it doesn't really help to do that in the treatment. So progression is where we've concentrated most of our activities over the last little while. So this injury gives rise to inflammation. We know inflammation is critical started off, always critical to start off. So you could say, all right, I'll continue to damage it, one after the other after the other. And if I continue to damage, I continue to have inflammation, I continue to stimulate this matrix repair, and I can build up scar. That's certainly capable, and that's mechanisms that we know occur in some of the diseases that we deal with pulmonary fibrosis or other organ fibrosis. So you could potentially have an intervention that deals with these repeat elements of tissue. But we also know that there is something that can happen in the tissue once these processes have started that ends up generating a progressive nature disease. You continue to lay down collagen no matter what, no indication that there is inflammation present. So there is an understanding of this progression has to involve some different way of thinking about what happens in the normal process to what happens in the abnormal process. So the hallmarks that we look at. These cells, these myofibroblasts that are built into the area we call fibroblastic foci, we call those as pathognomonic of IPF. If they're there, you certainly have it. But this area here is an area that is actually devoid of inflammation. There's no inflammatory cells in there. They're just abnormal cell populations that are fibroblasts, now with smooth muscle capacity and beginning to make a lot of collagen and laying that collagen down in this matrix area. So that is a good target, I think, in terms of understanding where we go. So you've got all of these scar tissues, and you can continue to destroy the normal area and modify the gas exchange. So let's go back into the scar. Now, the scar in this myofibroblast then, this is a cell population that has fibroblasts all painted all over it. And yet it has very, very remarkable content of contractile elements. Does it actually contract? We don't know. You can make them contract outside the body. Do they really contract in the body? We don't know, but the suspicion is there because they have everything that's just like a muscle cell has capacity. And you can trigger them with the ex vivo with all the same kinds of stimuli. So it's a very important cell population that we need to get to. And indeed, we have to take it apart. So in the laboratories, it's not easy to deal with the human tissue because you get a piece of human tissue and you can't keep it alive very long. So we have to resort to using animal models if we can. And indeed, we've got some good animal models. This is the human tissue with a myofibroblastic foci. This is a mouse that has been stimulated with a drug bleomycin that we can generate a pulmonary fibrosis. So we've got something similar to the kind of modified disease. And these are rats that have been treated in a way that I'll talk about that we've developed in order to transfer a gene into the lung that stimulates the progression of fibrosis. So we've got experimental models to test the hypothesis of whether these cells are critical and what kind of molecules they make. And that's really where we've spent most of our time. So when we talk about that fibroblastic foci that's growing down here, we have to know where the cells can come from. What are they? Well, certainly a normal cell that's present there already can receive some signals, and some of the signals, as you'll see, is a molecule called transforming growth factor beta, TGFbeta. It's a good name, it's a growth factor, it transforms in some cases, so therefore it's right at that cutting edge of a molecule that can cause oncogenesis or transformation, as well as a molecule that can stimulate growth and proliferation and making a variety of matrix proteins. So the cells can duplicate, divide, and get signals and become the myofibroblast. There is other indication that says that an epithelial cell can undergo epithelial to mesenchymal transition. It can change from an epithelium and enter into the interstitium and become a myofibroblast. That is under debate, and whether it's true or not, we really don't know, but it's a pathway that in cancer has been shown to be existing. And then there's a newer area that we can now follow, in which in the peripheral circulation there's a cell called the fibrocyte, which is a precursor or stem cell for mesenchymal tissue. And it will be brought into the tissue like any other inflammatory cell from the bone marrow, enter into the tissue and differentiate into a myofibroblast or affect a neighboring cell to become from a fibroblast to a myofibroblast. So we certainly have local tissues that will replace that. We have local tissues that will expand, and we have circulating tissues. All of these are testable hypotheses as to whether that's the right cell that we have to develop the drug for. And certainly there's now a lot of interest in that particular cell population, the fibrocyte, because it may well be one of those cells that we want to stop getting in, or if we get the question right, it may be the cell that we want to help get in. We don't know the answer to that yet. So there are several of those sources, and there is proliferation, exactly the same cell gets bigger, more of them, makes more of that scar. We think that's a possibility, and therefore, if that's true, then we should be able to get drugs that stop differentiation, drugs that stop proliferation. There's another one that talks about the transformation, that epithelial to mesenchymal transformation. And again, if that's true, then we need drugs that target a transformation process, if that's the kind of cell population. I'm saying all these terms because we do have drugs. The concept that you'll come away from here is that many of the drugs that we're now trying are drugs that have been in development by the pharmaceutical companies for many years for diseases that is proliferative, invasive, in other words, cancer. So many of the pathways that we're now working on, understanding this particular thing, has been the target of many of the pharmaceutical agencies in order to generate anti-cancer drugs, because the signaling is similar, the actual molecules are similar, and therefore there's been a huge amount of experience out there that we're now calling back into in the area of non-cancer but a proliferative disease or transformation disease. So this is worthwhile on the follow-up. And then the last one is the circulating progenitor cell. Right now, we don't know whether this is a stem cell, that is a stem cell targeted for the lung. It's certainly not a stem cell in the true sense of the word in terms of self-renewal cell population, but it has certainly a lot of capacity to be able to repopulate an area of injury and differentiate into a repair particular cell population. So this is bringing out some of the understandings of stem cell biology, and it's taking us into an area where we might say, do we want to provide more of these particular cell populations, or do we want to interfere with those cell populations getting to the injured tissue? That we don't know yet. So this is the fibrocyte. This is the signaling areas that people are beginning to target. Made in the bone marrow, like any other stem cell precursor cell, the blood precursor cell, the tissue precursor cells, made in the bone marrow. Once there's injury, there are molecules that will ask the bone marrow to make more, all of the colony stimulating factors. So we know about that. We don't really want to interfere with that. But that will then result in the circulating level of the cell, called the fibrocyte, which will then migrate to the area of injury and participate in the repair. Hopefully, it's correct. That is, as it gets there at the right time, it will cause repair. We don't know whether if it gets there at the wrong time, it will end up causing abnormal repair, and that's a real possibility. So targeting this circulating cell and targeting the molecules that generate it and targeting the molecules that cause it to go to the tissue is, again, a focus of where the developments are going. Now, we looked at these circulating cells here at McMaster. We're one of the few labs, the only lab in Canada is doing it, and one of the few labs in North America doing it. And in looking at the numbers of these individuals, the only thing that we've come up with to date has been that you can separate mortality or predicted mortality into two categories. If the individual on diagnosis has a circulating level that's above a particular level of fibrocyte, then their mortality is much faster than the individuals who have a lower level of fibrocyte count. This has yet to be investigated broadly in not only idiopathic pulmonary fibrosis, but other fibrosing diseases, kidney fibrosis or scleroderma or any of the other diseases, and by a lot more laboratories. Whether this is a biomarker or whether this is an indicator of progression, we don't know yet. But it clearly is a cell that is of interest and a cell that people are looking at. So when you look at the target we want to get to, the target you want to get to, we want to be able to differentiate between that cell that may be detrimental and this cell that may be beneficial. Harder to do if that's really the case because they look very similar. They got a little bit of differences, and therefore the drugs that we have to go after one cell population versus another are much, much, much more limited. So that is a qualifier for that particular thing. So then we come to the molecules that are involved. The old story about you can't see the forest for the trees, etc. Well, you can't see the growth factors for the trees in this thing. There are many, many, many growth factors. Every time you look for one, or every time somebody clones another one, you find them in repairing tissue. Not a big surprise. Growth and differentiation recapitulates development, and therefore all of the factors that are necessary to repair are these factors. And when we find them, we say, aha, this is the element. Well, all of these, and I guess we've looked at virtually all of them to date, there's only one or two that when we manipulate it and we look at it, that cell population or that individual molecule does cause progressive disease. All of the others are there. All of the others can contribute. But there's only one or two that will actually initiate and cause a progression of the disease. Now, I'll cut a long, long story short as to how we do it. We had to differentiate between all these. So we did, just putting this up because it's some of the data that I'd like to just show you. We've been able to transfer genes into the lungs of animals. So you take an individual gene that you're looking at and you put it into a flu virus, normal cold flu virus, the adenovirus. You put that gene in and then you put it into the lungs of the animal and it expresses in there only for a short period of time, 5 or 10 days. And then you ask what goes on in the interstitium. So we take a mouse or a rat, we have a virus that is now encoding the individual gene that we want, and by that injectable capacity, we'll transfer it into the lung area here of the animal, and it will go down into a certain depth. It will go down and incorporate into the epithelial cells in the animal, and now make that gene that we're interested in the animal, and we then begin to ask questions, does that gene cause a fibrotic change, and how long does that gene cause a fibrotic change? And doing all of that, summary part was the fact that there is really only one molecule that when it's present, it's capable of initiating a progressive disease, and that molecule is the molecule transforming growth factor beta. So there's loads of factors there. There are lots and lots of growth factors, but one factor stands out as being capable of doing this damage, and if you interfere with it, you're capable of blocking that damage. That sounds as if this is the perfect molecule. The caveat is this molecule does everything. It is a pleiotropic molecule. It certainly does the things I just talked about, but it also immensely affects the immune system and has a tremendous amount of capacity to modify the behavior of many, many different cell populations. So we fool with it at our peril, and that's true in some of the ways that we've looked at it. But it's important because it's a very complex molecule, and this is the molecule, the active component, that we're after. And it's really the only molecule that we're after. But it's held by a non-covalently, it's just caught in a pocket. It's caught in a pocket of another molecule, a latent molecule that you'll see in a minute, and that's tethered to another molecule, and that's tethered to matrix. So in other words, that's the active thing, but it can be painted all over the place, and it is indeed painted entirely all over the matrix that we have in our body. And it's important to know that because it's held here and it's not active, and it only has to be released before it can be active. That's the important component. So how does it get activated? Well, it gets activated by normal processes that we understand, and I'll show you another process. And those processes involve molecules called metalloproteinases, matrix metalloproteinases. They're around, they're in macrophages, they're in neutrophils, they're in epithelial cells, endothelial cells, and these metalloproteinases can actually clip these latent pieces and allow the active molecule to come out. Now these get activated usually during inflammation. So I can understand how progression can go if we have inflammation. You know, we're pretty good at treating inflammation. We've got very potent steroids. And under those conditions, we should be able to shut this process down. Well, we can shut that process down, but unfortunately, in fibrosis, in pulmonary fibrosis, in idiopathic pulmonary fibrosis, you cannot stop the progression of the disease. So yes, this is true. Yes, that's involved in some of the progressive diseases, but it's probably not involved necessarily in IPF because anti-inflammatories do not control this whole process. Not totally exclusive, but that's one of the arguments. Now, I'll go back to the experimental model. So we transfer the gene in, and once we've done that gene, it's in there by 7 or 8 days, and it's making it, but then it's gone. It's shut off. Now we end up seeing that early on, all the way through out to 56 days, we've generated a fibrotic response in the rat that's very similar to the progressive fibrotic response in the human. So can we use this model to ask the question? The answer is yes. Is it the model of idiopathic pulmonary fibrosis? No. It's a pure model where I've stimulated with a gene that I think is important, and we can now ask questions about that and put drugs into those animals that will end up changing it. A couple of quick things that actually changed our thinking about this progression. When we put that vector into the rat's lungs, we put it into the trachea, it goes down and it stays there in these large vessels or smaller vessels, infects them, makes the gene. Now we turn a process on that takes time, takes 14, 28 days. This is data that's now at the 28 days, where this is the outside surface of the lung, the outside surface, the pleural surface of the lung, and this is that control vector that we put in. So no difference, it's a normal looking lung. This is the outside surface where we put the vector that made TGFbeta. We put the vector days ago, and we put the vector a light year of distance molecularly away. We put it out in the larger areas. So the process that we have to look on progression involves time and it involves distance, and it's not fast. So if you think about people with pulmonary fibrosis, they don't get kidney fibrosis, they don't get liver fibrosis. If you have somebody who has liver fibrosis, they don't get lung fibrosis, and don't get kidney fibrosis. These are organ limited. So the process of fibrosis and progression has to be explained on the basis of mechanisms that will pass slowly from cell to cell. Not one burst of a soluble mediator that we can inhibit and travels through the circulation and causes damage somewhere. That's no longer viable. We have to think about it very differently. We have to think about it through the matrix, because that's how cells are stuck. They're stuck in a matrix. And the lung is a matrix. And the matrix contains a ton of different molecules. Collagens, elastins, fibronectins, these proteoglycans and glycosaminoglycans. This is a glue outside of the cell. And the glue is a true glue. It sticks cells together. Physically can stick cells together. You don't have, other than the peripheral blood, cells that are out there hanging around. They are stuck. They are stuck into the matrix and in communication with the matrix. Two important ones that we know about are the elastins and the collagens. And these are cross-linked. They're all held together in a relatively stiff but floppable manner. Certainly the lung is more floppable. So it's important to understand that. It's important because that area here that we're talking about is the area that we're talking about is going to be stuck up with many of these molecules, the growth factors. Now, a cell that's here is looking at the inside of the cell and the outside of the cell, and it's seeing this material that's out there. Now, that cell could, in fact, become abnormal. It could start putting out its own growth factors. TGFbeta, connective tissue growth factor, and that would be an inflammatory stimulation right there. But that molecules don't travel very far. They paint the matrix. And it's that capacity to now cause the matrix to be pro-fibrotic, passing its message from one cell population through the matrix to another cell population. That's where we have to target our drug interventions. That's where we have to be able to interfere with this slow, progressive disease. So, we know it's really true experimentally that we can cause that progression, but if you take cells like a fibroblast out and culture them on a piece of plastic, or pre-coat that plastic with different stiff material, the cells that are cultured on a very, very stiff material proliferate like hell. The cells that are cultured on a non-stiff material don't proliferate. How do we fit all that together in an understanding? Well, it comes down to tissue stretch. May well be the possible way in which we can understand this progression of fibrosis. And it comes to the work that a fellow now down in Toronto, which is Boris Hintz, published, and it follows the following argument. In these cells, these myofibroblasts that have contractile capacity, the inside of the cell has a contractile element. It is tethered covalently to an integrin, which sticks between the inside of the cell and the outside of the cell. And we know that that integrin is now covalently linked to a molecule that hides the TGF-beta active component, and that is covalently linked down here to the matrix. So that cell is tethered to the matrix. And if it pulls on that matrix by going under that, if the matrix is floppy, compliant, the actual physical force does nothing. If the matrix is stiff, the amount of force is necessary is capable of releasing the individual active component. You don't have to have a lot. And now you're generating that molecule, which we've already shown can capable of stimulating this progressive disease. So a mere physical aspect of causing contraction is capable of releasing a molecule which we know goes on to propagate the disease. And that's how we think some of these progressive diseases, and therefore targets now, the pharmaceutical development, are coming back to the area of endocrine biology that for years they tried and didn't understand it all that well, but they're certainly targeting this process here, and now there are other places that are targeting the resistant stiff extracellular matrix because it's an important component. That's a true argument whether you're looking at other organs or whether you're looking at the lung. But in particular, the lung, just think about this area here where physical force or mechanical stretch on the outside of that area that's now got all of this scar tissue is going to be quite different than the same kinds of forces in the inside, where there is this capable movement and you don't get the generation of the same signals. So we can make an argument that they're not the same anymore and that this is an area that would allow progression by the same thing of simply moving the individual lungs and causing the changes to occur. So we've built, one of the graduate students has built a mechanical transducer to ask whether this is really true. And indeed, by taking a piece of lung sliced and fibrotic and undertaking it and stretching it, he's able to demonstrate that you release active TGF-beta, and you can demonstrate that that released TGF-beta causes signal transduction in the cell. So experimentally, it's correct. We can target this aspect with now drugs in a development to ask whether we can interfere with the capacity to make that. And that's true with some of the materials that have been now tested in the experimental animal models. So let's come back to the last thing, the exacerbation, that progression. And the exacerbation is we do not understand. We certainly have an understanding right now that viruses should be able to do it. A viral infection a while ago, a week ago, a day ago, 10 days ago, 2 weeks ago, may well predispose the kind of damage that you see and the stimulation of these same molecules to cause enhancement of the progression. Does viral infection give rise to progression? Does it cause the outcome? There's a study that Martin and Luca Ricaldi did where they looked back at patient material and patient data, and the answer was that was not true. They could not find the presence of the viral remnants in order to cause the exacerbation. So this is an area that's unknown. We don't know how, we know it's important because exacerbation leads to deterioration, but we don't know what causes it, and we don't know whether or not antimicrobials may be of benefit. There's another study that's being planned right now on a long-term basis to look over a long period of time with a large number of patients on a daily reporting basis to see if we can pick up relationships between these. So the molecules and cells that may well be involved, you know about the macrophages because they come in as scavengers. They're bound to be important because they release molecules like the reactive oxygen species. These are damaging molecules that cause further tissue damage and progression. So what about what's going on out there and what have we got on our armamentarium that's being developed that will take us this forward? Because it's very complex, as one has argued. But if we hone it in, we know that TGF-beta is a target. We know that matrix is a target. We know that the fibrocyte or the fibrocyte precursor population may well be a target. And if we now factor that together with the fact that we need to have drugs that cause an inhibition of proliferation or differentiation, then maybe all of that coming together, we might be able to get 2 or 3 drugs that in collectiveness might be able to control this very, very complex disease. So, again, you're in every day you get an email from one of these producers of the map, and you see the map is much more complex. This is the current understanding of the signaling cascade of TGF-beta. I told you it's very, very important molecule. Regulates all kinds of responses, so you can't just block it out. But there have been developments in which clinical trials have gone on and are going on in using inhibition of TGF-beta with antibodies and interfering with the integrin with antibodies. There are serine threonine kinase inhibitors, and I'll talk a little bit, one more slide on the tyrosine kinase inhibitors. These I put up because they are in existence. They've been developed in cancer biology for a wide variety of other reasons. So a lot of these compounds that have these specificities are capable of being tested out and will be tested out in appropriate clinical trials over the period of the next 5 to 10 years in order to understand whether they can be useful. And it's really this issue about the kinases because it's the same molecules that will cause the stimulation and differentiation of tumor cells that end up causing the stimulation and transformation of the cells that are capable of making scar. And so tyrosine kinases, we all know that the inhibitors will block these areas that involve ATP binding, and we know that we're capable of being highly specific on that. There are clinical trials that are going on now with these types of inhibitors, because this one was just reported by a fellow who's going to come and visit us, Luca Ricaldi, just recently, in which Boehringer Ingelheim backed this particular trial, tyrosine kinase inhibitor in this large numbers, and it showed some efficacy. It showed an impact. This is one of the first trials in which there has been an efficacy at this stage of development that actually somebody can hang a hat on. All of the previous trials have shown a lack of efficacy or a lack of impact, but this one has some, and they're going into phase 3 as the next stage of it. And that's really encouraging. This is a broad spectrum tyrosine kinase inhibitor. It doesn't hit one of the tyrosine kinases, but hits at least 3 and maybe 4 or 5. So we're good there, because the outcome of really one of the major impacts here was a reduction in the rate of exacerbations. So when it comes down to understanding this process biologically, 2 things are important. One, the patient arrives with the disease, and therefore understanding how it got there isn't really going to help a lot unless it's progressing on the basis of that, and we don't think it does. So if we understand the process, then we know that it's slow, we know it's progressive, we know that it's probably too much of a good thing. That is, we do think that it is repair a little bit gone wrong. It doesn't have to go a lot wrong, because these are slow processes. In our laboratories, we can jam the process into a week or 10 days. In the human, it may be 5 months, 10 months, 2 years. So a little bit, as it continues, can go a long way. We know that progression requires contiguous nature. It doesn't progress out of the organ. So the mechanism of progression absolutely has to involve this contact, contiguous nature, and that's a target. We do know also that this concept of being able to generate the signals without having to have inflammation another way is capable of causing it, and it doesn't have to do it again, much more than 10% above background, because 10% over a 4-month period could be enough to cause that scar to continue to grow. We know these circulating cells are important, and they're going to be targets that one's working after. Indeed, we do have some hope, because as Martin showed you, the clinical trials have increased. Most importantly, the pharmaceutical industry interest has increased dramatically, because they've recognized that what we've gone through in the lung is exactly the same as what people have gone through or are going through in the liver or the kidney or the skin or the eye or the cardiac. And under those conditions, if they get a drug that has a promise in one of these organs, then the drug will probably have a promise in many of the other organs. And that means that we probably, over the next 5 to 10 years, will have a drug or drugs combinations that will target several parts of the mechanisms and end up hopefully providing a good management for the disease. We'll stop there.